Sorry, yes, I do recognize you for 5 minutes.
Thank you, Madam Chair. Thank you to the witnesses. Thank you, Director Carroll, for your service. As you know, buprenorphine has been crucial to the treatment of disease for opioid addiction. Currently, about 6% of doctors have the authorization to do that. I appreciate that you have called for increasing that goal to 10% in 5 years. I guess my question is, when you look at France's experience, where they had a major epidemic in the 1980s and early 1990s, they eliminated completely the similar waiver requirement, and my understanding is opioid overdoses dropped by nearly 80% after they did that. Why have a goal of only 10%? Why can't we be more aggressive in that?
Buprenorphine is a very effective medication for those suffering, but it is not without its own dangers, and so we do need to make certain that the people who are prescribing it are properly trained. The original cap for doctors, to make sure that they're able to focus in on the patients instead of just writing prescriptions for bupe, are not out of control. Original cap was 100. The Secretary of HHS engaged in rulemaking and moved that patient up to 275. So we're seeing how that's going. But I think you're right, and that's one of the goals, is to make sure that bupe is more available, buprenorphine is more available to individuals who are suffering from the disease of addiction.
Would you be open to studying what France did and looking at how they managed to get rid of the waiver and seeing if there's something we can learn there?
We're working with HHS, and that's actually one of the things that they're doing now, is to make sure that everyone understands the impact and to see if there's, just like what we were doing with Huntington, the lessons learned.
Are you supportive if this Congress allocated $100 billion over 10 years to help you and others fight this opioid epidemic?
I'm certainly supportive of any effective, efficient means of taxpayer dollars to save lives. In terms of the right amount, it's hard to say what the right amount is, at least in the next 2 minutes and 4 seconds, but it's certainly in the CARE Act, the heart's there in terms of what we need to do to prevent this, treat this, and stop the flow from coming in.
And that's, of course, our chairman's bill, Chairman Cummings. Do you think that could be an area of potential bipartisan cooperation, that we get something like that passed?
I probably shouldn't say this publicly, but I actually enjoy a good relationship with Chairman Cummings. And yeah, please don't report that back. I hope the mic's off. On this issue, it really is bipartisan, and I have good conversations with Chairman Cummings, his counsel on minority and majority side, to try to figure out how we're going to do this and save lives. At the end of the day, that's all I think any of us care about. If we're going to save lives, how are we going to do it? How are we going to spend taxpayers' dollars wisely? These are tough questions, though.
Dr. Ratte, I wanted to ask you about the Vermont model, the hub and spoke system, which we have seen terrific success, where people are not just treated for their mental health issue and drug addiction, but also given counseling, given a way to reintegrate with society. What is your view of that hub and spoke model, and whether it could be replicated in other parts of the country?
We really have learned a lot from the hub and spoke model, and one of the ways in which it showed in Vermont to be helpful is by having primary care providers providing treatment, learning how to help manage individuals. You could increase treatment capacity significantly. In Delaware, we've created a similar model that we call the START system. But really, again, what's so important is that you engage people in treatment, that it's effective evidence-based treatment, which includes both the physical, the mental health, and the wraparound services that people need, and that it's really treated as a disease, which is why primary care providers and buprenorphine play an important role in just considering it just a disease like any other.
I'm glad you're making progress in Delaware. My understanding is in Vermont, and I'm not sure of the statistics in Delaware, opioid injections have actually fallen almost 90%. How much do you think that we can look to the expansion of Medicaid that helped the Vermont program, and how important do you think expanding Medicaid is to being able to deal with the opioid addiction?
It's so important that individuals have access to treatment, effective evidence-based treatment. And in our state, expanding Medicaid has been very helpful to increase access to treatment for individuals in that expansion group, but it's also enabled us to free up funding to be able to increase our overall treatment capacity, as well as increase some of those wraparound and other services that are important, including peer recovery coaches or working on addressing housing or other issues.